Hi, and welcome back to another video. I hope that everybody is doing well today. Before I hop into today's content for Think Thursday, I just wanted to get on here and really briefly say thank you to everybody that reached out to me after my last video that I posted, kind of just discussing mental health. It really means a lot. I already feel like a little, I don't know, like vulnerable having posted that, and that's just, but it should be an open discussion. I mean, all of us go through these different ups and downs with our mental health. And like I said in that video, I'm happy. Like, I'm very happy. I just definitely battle with some anxiety sometimes, and it manifests in different ways when I least expect it. And those who have anxiety definitely can relate. But anyway, so thank you just to everyone that reached out, and to those who reached out and said that they were kind of going through something similar or feeling the same, then definitely you're not alone. I can understand where you are coming from, absolutely. So for today, I'm going to be talking about evaluating a patient in the outpatient setting for the chief complaint of a decrease in hearing or hearing loss. And more specifically, just talking about some of those simple tests that you can do in the office to kind of evaluate their hearing loss. When patients report hearing loss, one of the important things to determine is if it's sensorineural or conductive hearing loss. I'm sure we all have heard of the Weber and the Rinne test, also the whisper test. They're very easy to do, very simple to use in the outpatient setting, and they really can give us a lot of information. Also, aside from just using these in clinical practice, they are definitely hot topics on the licensing exam for the nurse practitioner's license. So if you're going to study for your boards right now, or if you're planning to take that test soon, definitely something you want to have a good grasp on, because you'll likely see a question on one of these, if not a couple of these tests on your exam. So we'll kind of just go over what those hearing tests are that you can do in the office and how to interpret the findings on those, and just very briefly talk about plan of care. But it's really about doing the tests and interpreting those tests. So let's just get into the material. And I actually drew like in my own illustration, which is, no one come at me, I'm not an artist. But you know what? Here's the funny thing. I always say that one great way to learn is to try and teach the material to others, because obviously then you have to be able to explain it from like foundational units and really comprehend what you're saying. Well, another great way to learn anatomy specifically would be to draw. Draw your illustrations. I drew like the anatomy of the ear, which you'll see here in a second. And, it's a very intricate, and there's a lot going on between the outer, the middle, and the inner ear. And that definitely gave me a better grasp on what is going on, like anatomically, having to draw it. And I remember when I was in anatomy and physiology class, like back when I was doing prereqs for nursing, and we had like a coloring book that we had to do, like an anatomy and physiology coloring book. And I remember thinking it was really cool and exciting, but I don't think I really understood just how helpful and useful that information would be in the future. But like, I almost want to get like a new anatomy and physiology coloring book just to kind of go through and get a better understanding of anatomy, because it was definitely a good learning curve. So yeah, if you want to learn some anatomy, draw your own stuff, because that is challenging. But let's just hop into the material for today.
So hearing loss is a common problem that everyone experiences at some point in their day-to-day life. So for example, a common cause of a decrease in hearing would be a cerumen impaction, or as we know, earwax, which is typically benign. But other more serious things such as Meniere's disease can also be associated with hearing loss. And this is associated with sensorineural hearing loss, which can actually result in permanent damage. Therefore, as primary care providers, it's really important to be able to determine the different types of hearing loss and when a patient should have that urgent referral to a specialist. So like I said, there's a couple of super easy to use tests that you can do in the office when evaluating a patient with hearing loss or a decrease in hearing. These are also very hot topics for the boards exam, like I had already mentioned as well. So definitely if you're studying for your boards, make sure you have a good grasp on this. All right, so like I said, we're going to briefly discuss these hearing tests we can use in the outpatient setting, how to interpret them, and then like a very broad plan of care. So first, let's talk about the whisper test. So the whisper test, this is done by standing at an arm's length behind the patient, And this is to avoid the possibility of the patient reading your lips. And then you'll have the patient cover one ear at a time. And while one ear is covered, you go ahead and whisper a short sequence of letters and numbers. And then what you do is you ask the patient then to repeat it. And you'll repeat that with both ears. So I included the sensitivity and specificity here. So the whisper voice test has a sensitivity of 90 to 100% and a specificity of 70 to 87% when evaluating hearing impairments in adults. So this means that a positive whispered test accurately diagnoses a hearing impairment in an adult 90 to 100% of the time, and a negative whispered test accurately rules out a hearing impairment in an adult 70 to 87% of the time. If you follow me on Instagram, then you probably saw I made like a little cheat sheet for comprehending both sensitivity and specificity. Has like a little memory trick on there for you guys. Definitely, like I said, a very important concept to be familiar with, especially if you're going to study your boards, but also just really useful information to have an understanding when you're doing research on your own and trying to pick best practice. But yeah, so if you haven't already, I definitely recommend going over to my Instagram. You can check out that graphic I made. I think it's really helpful. My Instagram, it's @thenewmp. I will maybe put it on the screen here, and if nothing else, it's always in that description box below. But there you'll find that little sensitivity specificity trick. All right, anyway, so back to the material. So when you're evaluating an adult with a unilateral decrease in hearing, the Weber and Rinne test can be used to determine if that hearing loss is conductive or sensory neural in nature. So to perform that Weber test, we get our tuning fork and we want it to be vibrating, and we place it midline on the patient's forehead. If a person either has no hearing loss or if they have symmetric hearing loss, then the sound is going to be heard equally on both sides. And so with the Weber, the tuning fork is at that midline of the forehead. So now with conductive hearing loss, the sound is going to be lateralized to the affected ear, meaning that they hear the sound better with the affected ear. So conductive hearing loss, this is a decrease in hearing that occurs due to the inability of sound from the outside world to gain access to that inner ear. In order for us to hear sound, it has to be able to travel from that external ear to the inner ear, and this involves like the cochlea and the auditory nerve. You can see there on my lovely illustration. So what is something that could block the sound from getting in? Well, what about, like we said, a cerumen impaction or earwax? Or what about fluid in the ear? So when you see middle ear fluid that we sometimes see with acute otitis media, or fluid and debris that's with acute otitis externa or swimmer's ear. All of those are going to be examples that could cause conductive hearing loss. But why does the sound lateralize to the affected side with conductive hearing loss? And that can be kind of odd. Why do they hear that sound more with that tuning fork on their affected ear? So this is because the ear with the conductive hearing loss is only receiving input from that bone conduction, not air conduction. Because remember, with conductive hearing loss, the sound is unable to gain access to the inner ear. So that perceived loudness that they're getting when you do the Weber test on that affected side, that perceived loudness, it's actually associated with bone conduction, which is sound created by vibrations of bone, predominantly here being the skull bones. So with sensory neural hearing loss, the sound is lateralized to the unaffected ear. And this is because sensory neural hearing loss is associated with inner ear disease. So sound is able to travel from the external ear to the inside, however, it's not accurately processed. So Meniere's disease and acoustic neuroma, these are both something that can be associated with sensory neural hearing loss and obviously are much more serious. So I remembered the mnemonic SUCK, S-U-C-K, and it's a mnemonic to help you remember the interpretations of the Weber test. So it's S-U-C-A, SUCK, and this stands for sensory neural unaffected, conductive affected, because with sensory neural hearing loss, sound lateralizes to the unaffected ear, and then with conductive hearing loss, sound lateralizes to the affected ear. SUCA, S-U-C-A, sensory neural, unaffected, conductive, affected. So the Rinne test, so this compares sound and by placing a vibrating tuning fork on the mastoid bone and then comparing that sound heard when a vibrating tuning fork is held near the ear. So the sound that's portrayed at the mastoid bone, this represents bone conduction. It actually is touching the patient, compared to sound heard with the tuning fork that's placed near the ear, not actually touching the patient. And this is representative of air conduction. So the Rinne test, this is considered normal when the vibrating tuning fork placed near the ear is louder than when it's placed on the mastoid bone, meaning that air conduction is greater than bone conduction. That is what that means. And air conduction greater than bone conduction is a normal finding. That's a normal Rinne test finding. Bone conduction that's greater than air conduction, now that is an abnormal finding. So to remember for the Rinne test, a normal finding is A before B. A always comes before B in the alphabet, and A comes before B in the Rinne test as well. Air conduction is greater than bone conduction. So an abnormal Rinne test or bone conduction greater than air conduction, this is consistent with conductive hearing loss. And this is especially true if that Weber test also lateralizes to that same side. Because remember, with conductive hearing loss, the sound lateralizes to the affected side. So patients with an unexplained conductive hearing loss or those that experience sensory neural hearing loss, these patients are going to require a further workup. Also, patients with hearing loss that have an unknown etiology, meaning you don't know why they're experiencing this decrease in hearing. They don't have an ear infection, they don't have earwax in their ear, there's no fluid, there's no debris. You don't know why they're having this decrease in hearing. This requires a referral to an otolaryngologist. Oh, I hope I said that right. Or an ENT specialist, so some sort of specialist. Any patients with sudden sensory neural hearing loss, this requires urgent referral on your part, because the treatment success for this is directly correlated to early onset of treatment. So the sooner the better with these patients. If they have sudden sensory neural hearing loss, that is an urgent referral, because this is technically, that's a hearing loss emergency. That could be a hearing emergency.
All right, well, I think that is going to be all for today's video. Hopefully you enjoyed the material and you really feel like you comprehend it better now, like really understand it. Because I remember when I was studying for my boards, I definitely had this memorized. I could reiterate the information to you, but I don't know that I really understood why we performed the test and what the interpretations really meant. And so now having a much better understanding of why and what for these tests, they're really intuitive and they're super easy and they should be used more often. So anyways, that is going to be all for today's video. Make sure you like the video. Make sure to subscribe to the channel as well. I really appreciate all the support and the growing numbers. It means a lot to me, and I really, really enjoy this YouTube channel and building on this content here. This is definitely one of my biggest hobbies. And so just thank you for being a part of my community. Thank you for showing up in the comment section and giving me, words of encouragement. Just thank you for being here. I appreciate it. So until next time, don't forget to learn something new every day, and I will talk to you guys very soon.
Wake up, today's gonna be a good day. 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 Yo, set your affirmations, aspirations. I got shit to do, the aftermath of preparation. Good food, good mood, blood in circulation. One step at a time, yeah, that's how you make it. Set a goal you control and the steps you take them. I try to pick one thought, have some concentration. And if I make a mistake, it's called education. I try to do this every day, call it replication. Wake up, today's gonna be a good day. Wake up, today's gonna be a good day.